Hey everybody, this is Sarah Greger. I am an emergency physician and intensivist at UCLA. And today we are talking about unstable AFib in 7 questions. The question number 0 when you're talking about unstable AFib is, what do we mean by unstable? Because there's unstable and then there's unstable. I remember thinking that, unstable AFib, okay, they're unstable, they have a low blood pressure, that means we need to shock immediately. We go down the unstable AFib pathway. And that kind of in my head was, shock immediately or else something horrible will happen. Turns out, as many things, it's not quite that simple. It is sometimes the case that the patient is so unstable because of their AFib that if you don't get them out of it or do something pretty immediately, they're going to rapidly deteriorate hemodynamically. That is true. That happens sometimes. But that's not nearly as often as a patient who has sort of a low MAP who also is an AFib. And that's a very different situation. In that situation, which as I said is much more common, you have a minute to think and figure things out. And that's important to realize, because the thing is, this sort of AFib, it's not just about deciding between a beta blocker and a calcium channel blocker. I remember feeling like that was the main decision, right? Like when I was presenting a patient with AFib, unstable or not, really the question was, okay, did I shock them? No. If not, beta blocker or calcium channel blocker. And there's this whole debate, right? Like people would cite this most recent paper, but then sometimes cardiology likes beta blockers, but sometimes we like DILT, and on and on and on. There was never really a winner of this debate, but more importantly, I think it's kind of beside the point. Because a winner of this debate is just not even the right question. We shouldn't be viewing AFib as shock versus beta blocker, calcium channel blocker. Really, in fact, it's much more complicated, and what we actually need is to realize that we need a toolbox. And there are multiple different tools in that toolbox. One is not necessarily better than the other. We just need to understand what the tools are and when and how to use them appropriately. Question 1. The first thing you have to think very carefully about is the AFib primary or secondary? We're having a chicken egg problem, right? Is the patient unstable because they're an AFib? Or are they an AFib because they're unstable? Because that happens all the time, right? That the patient will be septic or they'll be bleeding to death, and their response to that physiologic stress is to go into AFib. And you'll often see that with older people who have sick hearts. You know, a normal person, a normal physiologic stress response will be sinus tachycardia. But in an elderly person with a sick heart, or just in somebody who's prone to tachydysrhythmias, their physiologic stress response may be AFib. And if that's the case, then, they are unstable and they're an AFib, but these things are sort of true unrelated, or at least, the AFib's not causing the instability. And if that's the case, what you don't want to do is try and control the AFib. What you want to do is fix the underlying problem. Same way as like sinus tachycardia, right? Do we give beta blockers for sinus tachycardia? No. Why? Because you treat the underlying cause of the sinus tachycardia, not the sinus tachycardia itself. And when somebody's in a secondary AFib, then you want to start out by treating the underlying cause. Because if you don't, and you give them something to slow them down when that's their compensatory physiologic stress response, you can actually cause them some harm. Now, sometimes it is the case that the patient is unstable, they're hypotensive, because they are in AFib. And that does happen sometimes. And if that is the case, then you do need to do something about the AFib. But if that is the case, the next question you now need to ask yourself is, are they unstable because of the rate or because of the rhythm of AFib? Because we always kind of assume rate, right? Like we're always like, just rate control, who cares about rhythm? Now, for some patients, that may be true. They may be hanging out at a rate of 180 and their heart is just like, nope, not handling this well. But what about those patients whose heart rate's like 110, 115? Nobody should be unstable just because of a rate of 115. Like that doesn't make a whole lot of sense, So if we're saying that this patient is unstable because of the AFib, but their rate's only 115, really? It can happen. The reason is because some patients really desperately need that atrial kick, and when they lose it, no matter how slow that AFib is going, if they lose the atrial kick, even at a normal rate, they start to decompensate. This is particularly true in people who have bad diastolic dysfunction. Lots of elderly people do, lots of people with heart failure, bad diastolic dysfunction, and it's especially bad in people with aortic stenosis, people who just need that kick, need that atrial kick for diastolic filling. So if you have a patient who you're like, no, I really believe this is a primary AFib that's causing the instability, but I've slowed them down and they're not getting better, or they're not that fast to begin with, then maybe you need to think about, is this a rate problem or is this actually a rhythm problem? And no matter whether I correct the rate or not, if I don't fix the rhythm, they won't get better. Now, this leads us to the question of when to shock, and who to shock, and how to shock, and why. Again, my sort of idea that I had going into residency that okay, they meet criteria, they're unstable, bam, electricity, call it a day. If only it were that simple. The first thing is that you probably don't need to jump the gun quite so much, because again, most patients are not necessarily going to drop dead now if you don't shock their AFib in the next 10 seconds. But more importantly, it often doesn't work. Shocking AFib is not that easy. It often just won't cardiovert. It especially won't cardiovert if they've been in it for a while. It just likes to hang out. It can be resistant. So the first thing is, if I'm going to shock AFib, I always just start at 200 and just do it. But the second thing is, I'll sometimes try an initial defibrillation if I really believe, or really shock, if I really believe that they're unstable because of the AFib, but often what I find is that I need to correct some other stuff first before electricity will work. And so often that means I need to correct their electrolytes or their fluid status, as we'll talk about, and sometimes that means I need to maybe marinate them in a little amiodarone or something else before I shock them for it to be effective. So there's deciding if you need to shock, and if you think they're truly so unstable, you need to shock right this second. But then there's also okay, I tried to shock, or I'm not even gonna try because I'm not sure it's gonna be successful. I'm gonna sort of tee them up, I'm gonna treat some stuff, and then if that doesn't work, I'm gonna try to shock. And that's a very reasonable thing to do. And so I think about shocking in the bigger picture context of, one, do I need to, from an instability, do I need to right now? And two, do I need to optimize them before trying to shock them to make sure it's gonna work? Because the patient certainly notices if they get one shock or two, and they're not gonna be very happy if you shock them and they're awake and you're like, oh, it didn't work, we'll just have to keep trying. So if it's possible to optimize it the first time, fantastic. Now, we're gonna get into the conversation about anticoagulation. Do you need to anticoagulate? If we're talking about unstable AFib, the sort of baseline paradigm is unstable equals shock, at which point you're not really worrying about that so much. I would say that in the particular case where the instability is equivocal, I would treat some other stuff, see if I can get them better, try and get them stable that way. And then, you can shock them or cardiovert them if you really need to, but sometimes you don't even need to have this whole agonizing over are they anticoagulated, because it becomes moot because you don't end up needing to shock them in the first place because you can get them under control with some other stuff. So other stuff like what? Electrolytes. We really, really underestimate the degree to which electrolytes cause you AFib problems. Basically, if your potassium and magnesium are low, you can kind of do whatever you want. You can give them a bunch of beta blockers or calcium channel blockers or whatever. You can shock them 7 times. And if their potassium and magnesium are low enough, they won't necessarily convert. And it's always been amazing to me how much I'll be losing my mind and being real creative with drug dosing. And then I'm like, oh, their mag is 1.4. When I am correcting potassium and magnesium, I go for a mag of greater than 2.2 and a potassium of greater than 4.4. If I'm giving mag, I'll give 2, 4, however many grams. You're not gonna kill them with making them hypermagnesiemic. I mean, it's hypothetically possible. It's really unlikely that somebody's gonna come in and you're gonna give them so much mag they stop breathing. If their mag goes up to 3, okay, that's not my target, but it's not a dire problem. So if I'm gonna err in one direction, I give them a little extra mag. When I'm repleting potassium, I give it both PO and IV. It takes forever to replete potassium IV. So I give PO and I give the liquid form because it's so much faster. So I replete both of them aggressively, because if you don't do that, you're often not gonna get anywhere. Fluid status. So this is a big thing. And unfortunately, you can go into AFib by either being hypervolemic or hypovolemic. One of the things that the atria don't like is rapid, stretchy, unstretchy. They don't love that. And so if you have sometimes a rapid intravascular volume bolus, even if the volume bolus isn't that big, if it's fast enough, sometimes you can put somebody into AFib. And I see this situation all the time. You'll have an elderly person. They come in and they're in AFib. And they maybe had bad diastolic dysfunction. They're a little hypotensive. We're like, I don't know, are they septic? What's happening? We give them a little volume bolus. And even that small volume bolus, because of their diastolic dysfunction, actually, if you give it fast enough, it can cause some rapid atrial stretch. And then the patient goes into AFib. And you're like, what happened? I didn't even give them that much volume. And then they go into AFib. So rapid atrial stretch, or, if they're bleeding to death, if they're super hypovolemic, that can cause you problems too. Figuring out somebody's volume status is very tricky. We have a whole lecture series just on that. But sometimes too much volume as well as too little can cause you some AFib problems. And so trying to figure out if they're obviously hyper or hypovolemic and if you need to correct that. With the caveat that if you think you need to diurese them, you better replete their magnesium and potassium first. Next, intrinsic sympathetic activity. So these patients are often kind of freaked out, They're in the hospital, you're threatening to shock them with electricity, it's the ED, it's loud, and they have their own endogenous epinephrine drip going, right? And so, they're getting excited, they're getting freaked out, and especially if you then go and shock them, that's really sympathetically activating, it turns out. So if you can get them to just calm down, chill out, sympathize them a little bit, especially if you're thinking you may need to shock them. So what I'll often do is before I shock them, I'll usually use fentanyl as one of my drugs of choice, or if they're in pain or if they're freaking out, because fentanyl is a sympatholytic. So it can be very helpful to sort of tamp down that intrinsic sympathetic activity. If I think I may need to shock them, the other thing I'll do is I'll start them on Precedex, because Precedex, what's the main side effects of Precedex? It drops their heart rate. Oh wait, they're in rapid AFib, that's fantastic. So Precedex can be a great thing to start. You can start it while they're still breathing and awake, it's totally fine. Then hopefully it'll chill them out a little bit. It'll hopefully slow down the heart rate a little bit. Then if you do end up needing to shock them, I'll go up on my Precedex some, I'll give them a little fentanyl on top of that, and sometimes that'll put them in a good space where you can shock them without setting off even more of their endogenous epidrip. Drugs. So drugs are actually the last thing here. Because if you don't do any or all of those other things, or at least you don't consider them, often drugs are just not where it's at. They're my sort of, okay, have I optimized everything else I need to optimize? Now what drug do I use? You also need to think about, there's really two categories of drugs you're thinking about here. One are your drugs to either rate control or rhythm control. Two are your drugs to manage hypotension. Because what do we say about AFib all the time? Well, I can't give them this, whether it's beta blocker, calcium channel blocker, or I can't sedate them because they're hypotensive, so I can't even sedate them to shock them. We have medications for that. It's called pressors. It's called push-dose phenylephrine, is a wonderful thing. You can even do a levofed drip if you need to. But, I sort of see this as a you break it, you buy it thing, right? Like, we can have an argument about the evidence for push-dose pressors all day. Here's my take. If I am doing something that I know is going to make the patient hypotensive, I give them a drug, I know it's going to make them hypotensive, then I am now allowed to give them a drug to fix it. I break it, I buy it. It also takes all this angst about, well, I give them Versed, then I can't, then I shock them. You just give them a little push of push-dose phenylephrine. I like push-dose phenylephrine in this situation because it's just an alpha agonist. It doesn't give you any beta activity, so it doesn't increase your heart rate faster. So I like push-dose phenylephrine, and just, you can use it. Now, if you really want to give a beta blocker or calcium channel blocker, you can use push-dose phenylephrine to stabilize their blood pressure while you're giving it. And if you really believe that they're unstable because of the AFib, and you're like, I just need to slow them down a little bit, maybe give them a little push-dose phenylephrine so that I can sort of keep them stable right around when I'm giving the drug, fantastic. Usually for unstable AFib, though, I don't tend to give beta blockers or calcium channel blockers. Why? Well, firstly, it could be a secondary AFib. Even if I'm pretty sure it's primary, I don't know. It could be a secondary unstable AFib. And if my patient is in shock, pick whatever kind you want. Septic, cardiogenic, hemorrhagic, you know what I don't want to do? Give them beta blockers. That will not help them. In fact, it will probably hurt them. I don't want to give them a cardiac depressant, particularly because often the patients who do go into secondary AFib are the ones whose hearts may not be so great underlying. And so acutely, when they're acutely in shock, Do I really want to give them a cardiac depressant like a beta blocker or calcium channel blocker? No. On top of that, if I'm wrong and I'm like, oh, it was just the AFib, I'm just gonna, slow them down with a beta blocker. Just kidding, they're in profound septic shock. Now I need to start norepi. Oh wait, look what I've just done. I've just given a bunch of beta blocker. Now I'm gonna try and give a beta agonist. I am just being directly counterproductive. So what I like to do in these patients is I've done all the things I have to correct everything else. My drug of choice in the patient with AFib who's truly unstable is amiodarone. I like amiodarone. Now, is it going to potentially rhythm convert them rather than just rate control them? Yes. But if we're already talking about a patient who's so unstable we were going to shock them anyways, then that doesn't really matter. And it won't always rhythm convert them. It'll often just rate control them. And I like it because it's going to make them less hypotensive. But more importantly, unlike a beta blocker, it's not directly antagonistic to the drugs I would be then starting to support their blood pressure, and it's not a cardiac depressant like a calcium channel blocker. So I tend to give amiodarone 150 milligrams. I'll give a bolus, I'll give a second bolus, I'll start a drip. Digoxin is a wonderful medication. The problem with it in patients with unstable AFib is it takes forever. With beta blockers, calcium channel blockers, amiodarone, great. Like, you can give them, they work. With dig, it takes a while to dig load them. It's not going to help them in the next hour or two. And so I like it, it's a great drug, but if they're really that unstable that I'm worried about it, then that's probably not the way that I'm going to go. So overall, let's review. Unstable AFib. You're going to do this in 7 questions. Your first question is it primary or is it secondary? Is it that they have some kind of underlying physiologic stress that's causing the AFib, in which case treat that, or is it that the AFib itself is making them unstable? If we believe that the AFib itself is making them unstable, then you got to decide. Do you think that it's a rate problem, their rate's just too fast? Or do you think that this is a patient who maybe has some aortic stenosis, some diastolic dysfunction, and they actually need to be out of the rhythm of AFib because they need their atrial kickback? The next question is, when do you shock them? And this is not straightforward. Sometimes it's truly emergent, you just have to do it or else they'll code. That doesn't happen all that often, actually. You need to decide, do I think that I need to correct some stuff? Do I need to correct the electrolytes? Maybe give them a little amiodarone to start with before I shock them to get it to work? Or do I think that, I have a pretty good chance? Furthermore, do I think that I can give them something to sedate them to shock them? Because if I don't, and all shocking does is A, not convert them, and B, get their own sympathetic activity going, that's not really helping me. So not being afraid to shock them, but also being thoughtful about when and how you do it. Electrolytes. No matter what else you do to your patient, if their potassium and magnesium are non-existent, nothing else you do will fix their AFib. So aggressively correct their electrolytes. I target a MAG of 2.2, a K of 4.4, give whatever you need to do, because often nothing else will work until you do this. Fluid status, both hyper and hypovolemia can cause AFib, and sometimes a rapid volume bolus in a patient, say with diastolic dysfunction, where you get rapid atrial stretch, can cause them to go into AFib. So if you can get a clear take on their volume status, sometimes you need to address that in order to resolve the AFib. Sympathetic tone. Getting the patient's own endogenous epinephrine drip going is not helping your AFib. All that beta stimulation, not so much. So if they're freaking out, super anxious, sympathetically activated, and or you're about to shock them, doing something to calm all that down can be very helpful. Fentanyl is a great sympatholytic. Precedex is a drug that I often use even before I'm thinking about shocking them to just chill the situation down, maybe bringing the heart rate down, that you can do while they're still awake. And then medications are actually your last consideration. Be very thoughtful with beta blockers and calcium channel blockers in a patient who's truly unstable, especially if you think it's a secondary AFib. But don't just think about beta blockers or calcium channel blockers. Also think about blood pressure medications. So do you need to give some push dose phenylephrine? I'll give 50 to 100, 150 micrograms of phenylephrine as a push dose. You can even start a drip. You can start a norepi drip as well. In this particular case, phenylephrine is probably optimal. Ideally, though, you'll give a medication that doesn't have a significant cardiodepressant effect. I prefer amio in this situation with unstable AFib, 1, because it's less likely to make them hypotensive, and 2, if I'm thinking I'm gonna have to give them something like Levophed in case I'm wrong and they're actually in septic shock, then I haven't just shot myself in the foot. So overall, AFib's more complicated than the great beta blocker versus calcium channel blocker debate. The good news about this is that it gives you multiple tools and ways of thinking about it, so that hopefully the next time you encounter your patient with unstable AFib, it's a little bit less scary. The end. Thanks.